It's not going to happen.
That's a great point. Two things to answer that. Number one, we should be discussing a multifocal lens with our patients because they have the right to know that that option exists. Okay, so, and it maybe increases chair time a little bit, but I think it would be a disservice to not mention it, and then they come back and then they find out that there was this other option and they never heard about it, and you know, that's kind of a conundrum there. And then number two, honestly, when I go through, literally it takes maybe 30 seconds extra, for at least for me when I'm talking to my patients about this lens. It's not, I just literally say, because we already tell them, or at least we should, hey, you're gonna, you know, this is what we expect for your refractive outcome, right? We talked to them about refractive outcomes already. That you're gonna, you know, hopefully we're aiming for distance, do you want to be for near, et cetera, monovision, whatever. So we're talking to them already about that, and you just say, you know, that by the way, there's this other lens that we can put in your eye that lets you see up close and far away. It's not perfect, it's not going to make it so you don't ever need reading glasses, but it'll make you much less dependent on glasses for reading. And then I give them the example of the cell phone and the can of soup. You're not going to need this, you know, you're not going to need to put on your readers every time you grab your cell phone or every time you go to the store. And I tell them the price, and I say, you know, no pressure. And then I give them another example. I say, you know, because, one second, just because they're kind of confused. Like, a lot of times they ask me this question, like, oh, does an insurance cover this, or is this, you know, so is this part of the cataract surgery? I tell them, it's like getting an airline ticket. We're going to fly you wherever you need to go. But if you want to upgrade to first class or business class, that's on you. and that actually... That sounds like something private practice. No. But I don't mean it in a negative way. I'm just saying, I'm saying if because they're not sure if, so I'm saying no matter what Kaiser and your insurance is going to get you, the cataract surgery, you're going to get a lens. It's just if you want to get the one that lets you see up close and far away, you know, that's why it's out of pocket. And they usually understand that, you know.
So let me get you back on track just to finish the slides.
Sure.
So, because I have a feeling all of your thoughts did actually to finish the slides, because I have a feeling we all kind of know what you're saying already. Okay.
Sure.
So let's finish the slides, and then we'll have, and the discussion will be more interesting.
Okay, sure. Next slide then, please. So I already addressed this one. Basically, it's not an additional burden on the OR staff. Okay, so this is a big one. The second one here, that I may be an argument against it, that there's a fear that if you increase compensation to the physician, that we're going to start pushing these lenses on patients either in an aggressive manner or those who don't really need it. And basically, as you pioneered the bilateral program, if that's a concern at all, we can do an ethical guideline. Say, hey, you know, no patients with any underlying disease. You know, they need to be very well informed about what the cost is, exactly what could happen with the halos, etc. Which, by the way, I tell them that too. I say, you know, for the first month or so, you may see some halos, but that goes away. So, anyways, in summary, Kaiser does way less multifocals than the community, and at least from 2018. 0.5% versus 9 to 10, 15% of the community. We're losing significant potential revenue in that we generated $338,000 from the premium lenses versus possible $3 to $5 million. I believe a big reason for the fact that we're so much less than outside is because of our compensation. So I believe that increasing compensation would increase revenue for the partnership. And this can be done very ethically and would be good for all. Thank you. All right, go ahead. Sorry, yeah.
Well, thank you for the talk. It's a very, this topic, whenever it comes up, it's always just like, oh, it just, you know, starts churning up all these thoughts. But at Downey, what we do for a cataract evaluation is very straightforward. Optometry usually sends to us sometimes straight from primary care. We do a cataract evaluation, dilate the patient, show them the AAO video, which I believe is about 7 years old now, so it doesn't cover the newer multifocals. And we see the patient, we discuss surgery, and we, you know, I have a Alcon poster on my honestly, at some point, our job, and what I believe, is not to sell anything. And I know about, cost model and private practice lines. And I've seen the nightmare cases from private practice, where one eye had the crystal lens, the other one had a Tecnis multifocal, and the patient's still complaining about it 10 years later. I think, and I used to do what you were saying. I would kind of phrase it as, well, don't use the word premium. It's, don't think of it as premium and this is inferior. No, and I would say things like, oh, you need it in both eyes. I had one patient develop a 6-prism diopter deviation after 2 eyes multifocal and had diplopia. And that one patient convinced me to check strabismus on every single cataract patient and put it in my checklist. I have this little checklist for her.
But would that have happened just
You
because of the
never know.
multifocal?
You never
or
know
could
what's
it
going to
happen-
happen. That patient would have been better off with monofocals. In hindsight, 2020, you can't go back and do the surgery. Yeah, actually, you can remove a multifocal and put a mono, and I've done that before too. So, but anyway, the practice, I believe, has changed. We do not, as Kevin said, we do not have a model where it's packaged together with post-op LASIK. If we have a patient that's upset with 0.75 doctors of astigmatism, I really try to convince them, no, you'll be okay, okay. No, I have an occasional patient that I have to, unfortunately, have to ask Ray to check it out, and we don't have the package system.
Right.
We don't have a way of really letting patients know, these are all your options for lenses. I have a smart phrase, and I've developed, I've gone off the internet, I've taken pictures of all the different lenses and, given to the patient to help them understand educationally. These are the lenses, because I do believe, yes, you have to tell the patient what exists.
Right.
They ultimately will ask you, what would you do?
And my answer would be, if they're not my mom wasn't an engineer or ophthalmologist, I'd say yeah.
No, but honestly,
I would say you
the
should get it.
patient's right there. Yes, you've asked about their social history. You have one visit with them, and I do give them option, of course. Because I don't want to give patients 2 monofocals if that's not what they want. I totally agree with that. I won't do that if that's what the patient has 5 minutes to understand this technical details of IOLs, and you're showing them A-scan numbers. They don't understand a thing about this stuff.
I mean,
Right?
I understand. I understand.
So
what you're saying.
I do believe you have to do it individually, but our numbers, I believe the variability will represent, the numbers you see, the variability will represent how we are basically having to deal with them on the spot there. No, I don't use their career as a huge gauge of, I just literally ask them, what is it that you want? This is what you will get with this. I talk about monovision if they've tried it before, mini monovision for the non-dominant eye, all that stuff. They can check their dominance patterns. But we have 10 minutes to do all this stuff. So it's not an ideal circumstance. I think the numbers you see, all the challenges and variability that, some will do 75/70s, others won't. It just depends on your practice pattern of how you see these patients.
Sure. Sorry.
I haven't really thought about this before, but the toric IOLs went up 20% in January, and I don't think my reimbursement went up 20%. So that all went to health plan, and I never really thought about that. Like, why did that happen?
Right.
And did that decrease the volume of toric IOLs since the price increased?
Right.
Or what? Like, what was the story behind that? Why don't we charge more for multifocals if that's the case? If you make more money that way.
So we're probably gonna charge $1,500 for the multifocal. We went up from 1,000.
You mean for the
to
toric?
1200. I'm sorry, for the toric. We went up from 1,000 to
Went from 1,000 to 1,200.
Right, and so we'll probably go up to 1,500 based on some discussions we had this week at Eye Care Tech Committee. We're feeling that our price is low, but we don't know what that's gonna do to the volume. It might decrease the volume. Hard to say, but you're right, Melvin, is that we'll increase the price that the patient pays, but the surgeon's not getting more of that. That's all going to health plan. It's absolutely true. A lot of ways to look at this.
And And actually, toric is more.
I think Jeremy was next.
Sorry.
Go ahead, Blake.
No, I'm saying torics are actually more difficult than a multifocal.
Yeah.
And a multifocal, we're charging 2,500, of which we're collecting less than 5% of that.
But I suspect
And that's
that a
why
lot
there's
of
only
people put in
2%.
toric IOLs because they believe that fixing astigmatism is
Is
reasonable,
important.
and there's less negative like glare and halo.
Right.
And I believe that that's why there's more toric IOLs.
Right, exactly.
Jeremy,
Go ahead.
you're next.
Or, I know you had a question actually first, go ahead.
Question is, the proposals that you have, is this more theoretical, or is this something that you're pushing through, com committee?
Well, I'm just bringing it up for the first time.
But
Well,
is
you
this
guys-
something that's supported by,
It's the first time the chiefs are here.
I haven't
and then,
done anything to
and
be
then my
honest.
second comment, yeah, it's more a comment, is that I like that we can make more money for the organization, but I'm generally concerned about incentive programs to incentivize doctors to behave a certain way. Like we could actually save a ton more money by incentivizing random people to not use EYLEA. If you gave us each like $50 each time. such a proposal was like theoretically in existence like 6 years ago, but then we all kind of didn't want to do that because we were worried that it would incentivize behavior that wasn't optimal.
But if you think about it, we have a cataract incentive program.
Well, right,
And we
but-
already are using incentive, and the reason why is because before the incentive program, and let's not kid ourselves about human nature. Without incentivization, people, I mean, we all want to say we're the most moral and ethical people, but people in general tend to not try as hard. So we put that cataract incentive program in place, and it had dramatic results, correct? We went from doing 2 or 3 a week to 9 or 10.
So let me take a shot at Jeremy's question
Sure.
also. Is that, it's true, you know, this is just something that Blake has been thinking about and he brought up to us, and it's great to discuss here today, and I'll tell you why. Because Blake's heart is in the right place. He wants to earn income for Kaiser Permanente. He's not trying to line the cataract surgeon's pockets. I really believe his heart is for KP. And at some point what will happen is we'll have a recession and there will be a need for us to reduce our expenses and increase revenue, and the health plan's going to come to us and say, well, you can really help us if you push the multifocals. And well, we've already had this discussion and we already have this in mind, and we're not going to just say, okay, we'll push it harder. We'll say, okay, but it's not going to happen unless you incentivize us. So work with us. Let's figure out what the dollar amounts are that are correct, that will incentivize us, not tear our specialty apart, because pediatric ophthalmology, oculoplastics don't get them up. So at least we're starting somewhere. That's why I like you bringing this up.
Thank you. And finally, I mean, literally doing 2 multifocals per surgeon is, come on, I mean, there's a lot of patients. I'm sure all of you cataract surgeons have heard of them. Oh, I'm so happy, like the next day or a week later, whatever, your post-op day 1 or week 1. Oh, it's great, but I can't read anything. I mean, how many times have you heard that? Or they're 20/20 for distance, and you're like, oh, do you want to just get over-the-counter readers? And they're like, yeah, but I'd rather go to optometry to get a bifocal because I'm tired of doing this all day. And then I have my patient that I did the multifocals on, and they're like, this is amazing. I mean, that's almost every time I hear it, this is amazing. They're so happy. They're like, I hear 95% of my patients say, thank you for telling me about that lens. Thank you. And I believe in the lens because I've seen the results. And yes, there are the occasional nightmare patients or disasters, but in cataract surgery in general, we have occasional disasters. So are we not going to do cataract surgery? No, we still do it. We know there's going to be a horrible outcome here and there. And yes, maybe the multifocal does carry that risk, but overall, it has great results. Patients are very happy, especially if they do it bilaterally. And the crystal lens we're not doing, so multifocal crystal lens, whatnot, Sorry, I have a lot of questions. Go ahead. Yeah.
Ken,
I think this discussion would have been framed